Good morning, everyone. I want to first thank you for coming to this morning's and this week's Department of Medicine Grand Rounds. My name is Thomas Chen. I'm one of the new internal medicine chief residents. And today I have the pleasure of introducing our speaker, Dr. Eng. She is a native New Yorker, and after completing her PharmD, she came out with more questions than answers in medicine. She later obtained her MD from the Albert Einstein College of Medicine, followed by her internal medicine residency at Columbia University. She then went on to her pulmonary and critical care fellowship at right here at Sinai. She stayed on to be the inaugural fellow in the Interstitial Lung Disease program under Dr. Maria Padilla, and is now the associate director of the Interstitial Lung Disease program. Her special interests are incorporating artificial intelligence in the workup of ILDs and in genetic forms of ILDs. So if you can please join me in welcoming Dr. Eng.
Thank you, Dr. Chen. So the title of my talk is Interstitial Lung Diseases, Where We Are and Where We Are Going. No relevant disclosures to this talk. The objectives are twofold. One, I'd like to provide an overview of the ILDs, and two, to highlight part of the evolving landscape of ILDs. So if you're experienced with ILDs when it's anything like mine initially, it'll feel like alphabet soup. But my goal within this hour is to help unpack this, make it more digestible and palatable. So this is the outline we'll go through, starting with a case study. We have a 49-year-old gentleman, no past medical history. In December of 2023, he was admitted with hypoxemic respiratory failure requiring high-flow nasal cannula, thought secondary to pneumonia. Respiratory cultures grew Haemophilus influenza. There was also a concern for maybe organizing pneumonia based on the imaging, which we'll go through. He was given antibiotics and steroids, ultimately discharged on 2 liters of nasal cannula. By June of the following year, he was referred to me for further evaluation for persistent shortness of breath. Just to give you a frame of reference, prior to this, he had an unlimited exercise tolerance. Now he's barely able to walk 2 blocks and still required the use of nasal cannula. Review of systems, just pertinent positives, has reflux, snoring, and premature graying that started at 17 years of age. In terms of history, no notable environmental, occupational, or avocational exposures. I'll just highlight family history was notable for pulmonary fibrosis in his father. That was diagnosed at 72 years of age and passed away, unfortunately, about 5 years after that. On exam, he had bibasilar rales. Otherwise, the rest of his exam was unremarkable. No skin changes, joint issues, etc. Labs was only notable for a positive Sjogren's antibody at SSB, which was borderline. The upper limit of normal was 0.9, but otherwise the rest of his serologies was negative. He was sent to rheumatology, and they also agreed no other stigmata of a connective tissue disease, and this was not thought to be clinically meaningful. Pulmonary function testing was notable for mild restriction and a severe gas transfer defect. So with that, we'll go over the imaging. He had no prior imaging. This is during his hospitalization. What you can appreciate here is that there are diffuse bilateral ground glass opacities with dense consolidations. Looking at this, I'll play it over one more time for you guys. Looking at this, you might consider a multifocal pneumonia or kind of an overlap pattern of perhaps organizing pneumonia, multifocal pneumonia or organizing pneumonia with a non-specific interstitial pneumonia pattern, which we'll go through. Fast forward into when I saw him, this was his follow-up imaging. What you can appreciate here is that there is interval resolution of the kind of very impressive ground glass consolidative opacities, but there is residual disease, which is highlighted by kind of this peripheral reticular opacities that involve the upper as well as the lower lungs, with the lower lung predominance, and is associated with traction bronchiectasis. So what is the diagnosis? A, post-infectious or inflammatory scarring. Is this an ILD with the usual interstitial pneumonia pattern, non-specific interstitial pneumonia pattern, organizing pneumonia? None of the above, all of the above. My graphics didn't show, or this is all too confusing. So before we answer that, let's go through an overview of the ILDs. And I want to start by highlighting the magnitude of the problem. This is a slide showing the prevalence of ILDs over the last 3 decades, both globally and in the US. So the prevalence has roughly doubled over the last 3 decades. And this is for a multitude of reasons. One, there's increased awareness, but also improved diagnostics, which is great. But also, I think there is also a true increase in prevalence, which happens for a number of reasons. One, we see more pneumonitis or drug-induced lung diseases. We see a lot of referrals from oncology, from PD-L1 inhibitors or immunotherapies, but also greater prevalence because with an aging population, we know that a lot of ILDs happen in older individuals. So while prevalence has doubled, mortality has roughly quadrupled during this time frame. And the reasons for this is also multifold. One is there is significant difficulty in the diagnosis, which leads to delay in diagnosis as well as delay in treatments. And secondly, there are limited therapeutics, which we will discuss. Idiopathic pulmonary fibrosis is the prototypical and most common of the ILDs. Median survival is roughly 3 to 5 years, which is terrible. It's worse than most of the cancers, only trailing behind that of the pancreas and the lung. And while IPF is the prototypical ILD that's characterized by progressive fibrosis and respiratory failure, the non-IPF fibrotic ILDs are not immune to this and suffer a similar trajectory. So here you can see in green that slide, the non-IPF fibrotic ILDs, about 60 to 70% are non-progressive, whereas about 30 to 40% do progress. And this ranges from the different subtypes of ILDs, from hypersensitivity pneumonias to connective tissue disease ILDs. And put another way, this just shows the survival curves where IPF has the worst prognosis, sarcoidosis actually has the best, but the other subtypes fall in between. But this does not even account for the morbidity that's associated with interstitial lung diseases. Patients are highly symptomatic. They suffer from shortness of breath, refractory, intractable cough that's difficult to manage, reduced exercise tolerance, and reduced quality of life. They have significant complications: respiratory failure, need for oxygen that is life-altering, acute exacerbation and hospitalizations, where when they get this, they don't return back to their baseline, they continually decline. They also have respiratory infections and comorbidities, including pulmonary hypertension, heart failure, reflux, sleep apnea, lung cancer. And that's important to note because patients with ILDs have an increased incidence of lung cancers. And it's also more difficult to detect in these patients because, as you can imagine, when you have all of that scarring happening, it's very hard to detect these nodules. And so when they do get detected, it tends to be at a later stage. And with all of this going on, it's not surprising they have more anxiety and depression. This is a study that was done at the end of life, comparing patients with ILD versus lung cancer, and it shows that the prevalence of any symptoms is the same. When they looked at very severe symptoms, it showed that breathlessness and cough was more prevalent in ILD patients than in lung cancer. And in fact, about 50% of these patients with ILD was on oxygen compared to 15% in lung cancer. And so with that understanding of the severity and burden of illness, let's review the ILDs. So very quickly, as you recall from anatomy, what I show here is the alveolar capillary interface where gas exchange occurs by diffusion. So diffusion is governed by Fick's law, which is proportional to surface area and concentration, and inversely proportional to the thickness of the membrane, which in this case is the interstitium. So anything that causes the interstitial space to expand will impair diffusion. And so this is the premise behind the ILDs because there's something infiltrating this space. So interstitial lung diseases, also known as diffuse parenchymal lung diseases, are classified as such. And so this is just to provide a schematic of what this looks like. This is based on the American Thoracic Society, European Respiratory Society classification guidelines. The main thing I want to highlight is that there are ILDs of known causes. So the most common ones you can see here: rheumatologic, systemic sclerosis, rheumatoid arthritis, myositis. This group encompasses, in our experience here at Sinai, the most common causes of ILDs. But also you can see environmental, occupational, drug or radiation induced is also a major one. And Dr. Robert Wright had a recent grand rounds here just about a month ago where he talked about the exposomics, which is essentially the totality of all of this. including internal and external factors that can also influence disease. Other causes are inherited, granulomatous, and other more rare forms of diseases are listed. And so this kind of picture here also depicts how we approach our evaluation of ILD patients, because whenever we see these patients, we have to think about all of these secondary etiologies and rule them out. So these are our considerations. And if we ruled out all of these secondary etiologies, we are left with an idiopathic interstitial pneumonia. And this is based on the also clinical data that we look at in addition to the radiographic patterns, of which idiopathic pulmonary fibrosis, as I mentioned, is the most common type. So kind of in the evaluation of ILD, just want to say we start with imaging. So this is just doesn't include all of the features that we look at, but I just wanted to give you a flavor of how we approach these patients. So when we look at the CAT scans, we want to think about the radiographic distribution. Does it affect the upper, middle, or lower lungs? Because each of these will clue you in one way or another on what's the likely pattern. Upper lungs, you can see in pleuroparenchymal fibroblastosis. Lower lung, you can see with the usual interstitial pneumonia pattern. Similarly, peripheral or central. Peripherally, we see with the usual interstitial pneumonia, whereas centrally, you can see with the nonspecific interstitial pneumonia, where there's central involvement. In this case, it actually beautifully highlights that there's subpleural sparing as well. So after understanding the distribution of the abnormalities, you want to know what are these abnormalities? What are the radiographic features? These are some of the common ones that are highlighted. You have ground glass, which is basically this hazy opacification. You have reticulations, which are these linear markings. You can see cysts, consolidation, honeycombing, which is defined as 3 to 5 stacked cysts and are indicative of fibrosis, as well as traction bronchiectasis, which are dilatation of the airways. You see mosaicism here, which are these patchy hyper and hypoattenuating areas that are suggestive of small airways disease, hypersensitivity pneumonitis, or pulmonary vascular diseases. And then you also have interlobular septal thickening, which is just along the anatomy of the septa, where you can have deposition that includes volume, as well as deposition disorders such as lysosomal storage disorders or amyloid. And so all of these radiographic features, they come together to ultimately give you a radiographic pattern. So usual interstitial pneumonia, UIP, is the most common one that we see. And this is based on histology based in the 1930s. Initially, when patients would have respiratory failure, they would find post-mortem that their histology showed this subpleural and peripheral fibrosis. Like you can see just under the pleura, that's where all the fibrosis is evident. And there's temporal and spatial heterogeneity, meaning there are areas of normal lung and abnormal lung that changes over time. There's also characteristic lesions of fibroblastic foci that are indicative of active areas of inflammation and honeycombing. So with the advent of CAT scans in the 70s, it was discovered that there are radiographic correlates to these histologic patterns. So on CT, the UIP pattern is you see basal subpleural reticulation with the requisite of honeycombing, but in the absence of alternative features. So you should not see ground glass, nodules, et cetera. I'm just going to highlight very briefly nonspecific interstitial pneumonia, just because it's another very common one where instead of being patchy, this is more uniform disease. On imaging, you see bilateral, symmetric ground glass reticular opacities. I won't go into all the others, but just to give you a flavor as well, you have hypersensitive pneumonitis, HP, organizing pneumonia, OP, and the others where there's a histology pattern as well as radiographic correlate that goes with it. And these are patterns. These are not diagnoses. And that's important to understand because a pattern of UIP, for example, can be seen across a number of disease conditions. We see it in connective tissue diseases, most commonly rheumatoid arthritis-associated ILD, hypersensitivity pneumonitis, as well as drug-induced diseases. And so after you've excluded all of these secondary etiologies, then you can confidently say this is likely an idiopathic pulmonary fibrosis. And this is true for the other radiographic patterns where you have to input all the clinical parameters, rule out the secondary causes, then you're left with an idiopathic form of that condition. So this is highlighted another way. You have your CAT scan. We put in all the other clinical data that we assess in our evaluation. Sometimes in rare cases, and in very specific particular cases, we may do a bronchoscopy with a lavage plus or minus transbronchial or a cryobiopsy. But overwhelmingly, we are able to get to a diagnosis non-invasively. And all of this data is presented to our multidisciplinary group, which is now the gold standard in terms of diagnosis for ILDs. The multidisciplinary team is comprised of pulmonologists, rheumatologists, pathologists, and radiologists, plus or minus some additional subspecialties as needed. We meet every Monday from 1 to 2 by Zoom. And so as you can see, it's not an easy task to come to a diagnosis of ILD. It's a very involved process, it's labor intensive, but ultimately a very rewarding endeavor. Unfortunately, what follows may not be the most, might not feel the most optimistic sometimes because there are limited therapeutics. This slide here shows all we have in terms of FDA-approved therapies for IPF. These are antifibrotics, of which there are two, nintedanib and pirfenidone. Unfortunately, they do not reverse or cure the disease. They also do not halt or stop the progression of fibrosis. What they do is which is still great, they slow down the progression, which is defined as reducing the decline in the forced vital capacity, which you can see in the graphs here. These studies were published in 2014, more than 10 years ago. And since then, there had been no positive studies until last month. This was published in the New England Journal. Nerandomilast was found to slow the decline in FVC, similar to the other drugs, which is great to have, but just to highlight, we still unfortunately don't have a cure or anything that can stop the disease. In terms of the non-IPF forms, I'm just going to highlight quickly, treatment is targeted at the underlying etiology. So CTD is, as mentioned, most common that we see here. And the specific CTD subtype matters because it determines what is the best immunosuppressive agent we should use or what's the best evidence we have. Unfortunately, randomized controlled trial data only exists mainly in the setting of systemic sclerosis with mycophenolate, cyclophosphamide, and tocilizumab. And as well as nintedanib, that's the only antifibrotic that is used in non-IPF fibrotic disease. Otherwise, the rest of the data is based on weaker non-RCT data or extrapolated from sclerosis. And then I'm not going to mention for the more rare diseases, there may be specific targets and treatments, but that's outside of the scope of this talk. And so clearly, there's a dearth of pharmacologic agents and more research is needed and is indeed being done. So this shows a landscape of the clinical trials that are active. Here, we are involved in 6 of these and are actively enrolling in more. In terms of non-pharmacologic management, supplemental oxygen is indicated. Screening and management of comorbidities is important. Reflux, pulmonary hypertension, sleep apnea, lung cancer, as well as referral to pulmonary rehabilitation, clinical trials, lung transplant. And of note, ILDs are now the leading indication for transplant, surpassing that of COPD in 2007. Referral to palliative care and management at an ILD center is also very important. So with that, we'll move on to our second objective, which is to discuss the evolving landscape of ILD, starting with artificial intelligence. So obviously, I'm not a data scientist, so I'll try to explain this the best that I can. The reason why we're looking into AI is because of the difficulty in the classification of the diagnosis and prognosis of ILDs. While CT is the cornerstone in the evaluation, there are limitations. There's inter-observer variability, so it's subjective. There's also low sensitivity in early and mild disease, lending to missed or delay in diagnosis, as well as overlapping radiographic features, like in our case, could look like a picture of usual interstitial pneumonia or nonspecific interstitial pneumonia. So sometimes there can be diagnostic uncertainty. There's also difficulty in quantifying changes over time, which limits prognostic utility. And so AI has been leveraged in the detection and quantification of ILDs. So at the core of AI is pattern recognition. So this is an example of texture analysis where basically you have volumes of interest taken from the CAT scan. And a radiologist will label these volumes as, for example, here, normal lung or ground glass, is this reticular or not, nodules or not, et cetera. And all of this information is fed into the computer to train it to recognize what are these different features or textures. An example of this being implemented is in the adaptive multiple features method, where you can see here the volume of interest is highlighted and is kind of scanned across the CAT scan. And each of these volumes are categorized by a radiologist to say, is this honeycombing, ground glass, et cetera. Another method to quantify and identify these radiographic features is this histogram signatures. What this is a quantitative representation of the distribution of the pixels or voxels. In this case, these are Hounsfield units. Um, and this is compared against the ground truth of histology. So these are examples of what started as machine learning, and all of this falls under the umbrella of artificial intelligence. So what machine learning deals with is small, simple data sets that requires pre-processing and is ultimately just tabulated data that is fed into the computer. Thereafter, it requires specific programming for each task to ultimately give you the output of car, not a car. Deep learning, on the other hand, deals with large data, with raw data, so images, videos, and it's fed into the computer and handled by a convolutional neural network, or CNN. The CNN has special layers to recognize patterns in the data at different levels. So ultimately, these CNNs are able to compress all of the data while maintaining spatial information. They're also able to continually learn and improve on their own without specific programming at each task. And so these are some examples of deep learning algorithms applied to ILDs. Here, mostly they've looked at radiographic patterns, which I just highlight the ones that are more robustly studied. And they look at UIP versus non-UIP. And you can see here the diagnostic accuracy for this discrimination was comparable to that of thoracic radiologists. UIP is on the bottom, non-UIP is on top. And furthermore, they show that there's prognostic utility in terms of these patients with a UIP pattern do worse than those with a non-UIP pattern. Another deep learning algorithm used is multiple instance learning. And here they show that the diagnostic accuracy was actually greater than radiologists, the ground truth here being histology. And similarly, they were able to show that discrimination matters and has prognostic value. So we asked the question, beyond the radiographic patterns, can we also incorporate clinical data to, one, identify ILD diagnostic subtypes, and two, to improve prognostication? So here we have the Mount Sinai ILD registry. This is a prospective registry that was started in 2014 by Dr. Maria Padilla, who is the director of ILD here. Since then, we have enrolled over 1,000 ILD patients with longitudinal data. So we collect a spectrum of clinical information, as you can see here. And in the future, our goal is to also collect blood samples. So Dr. Xuan Mei, who is a data scientist here, part of the Biomedical Engineering and Imaging Institute, has published on this with our ILD registry and has looked further into not just UIP or non-UIP, but also the other radiographic patterns, UIP, NSIP, et cetera, and show that there's greatest accuracy in UIP versus NSIP, and this is compared to a ground truth of the multidisciplinary group consensus diagnosis. And similarly, they were able to show that there was prognostic value with more clinical data that's added. So they looked at 3-year survival and showed that with more data that's clinical information added, less than 1 year to 3 years, the AUC increased from 0.6 to 0.86. And so our goal is to take this a step further and input not only the radiographic data, but also the spectrum of clinical longitudinal data that we have inputted into convolutional networks, and hope to predict the outcomes of not just the radiographic patterns, but also the ILD diagnostic subtypes, as well as look more into prognosis, including what are the factors that not just influence survival, but also development of comorbidities such as pulmonary hypertension, as well as lung cancer. So shifting gears into the other facet of ILD that is rapidly growing is genetics. And we've long known that there are genetic underpinnings to ILDs, from familial aggregation studies to the association of ILDs in multisystemic genetic syndrome. So for example, Hermansky-Pudlak syndrome, to the observation that only a subset of individuals exposed to fibrogenic agents, such as asbestos, develop the disease. And so these diseases are thought to occur in patients with exposures, but who have a genetic predisposition to disease. The relative contributions of genetics can vary between rare variants of large effect size to common variants of small effect size. So rare variants are defined as those that carry an allele frequency of less than 1%. And common variants are those that carry an allele frequency of greater than 5%. And this makes sense that they have inversely proportional effect sizes due to evolutionary pressures. Of the common variants, MUC5B is the most well-known and studied. It's been seen in approximately 30% of patients with ILDs, which is huge. However, as a common variant, it means that it's also seen in patients who do not have disease. So in genome-wide association studies, the control cohort, they found that 9 to 11% of those patients also carry the disease. So clearly there is an increased risk if you carry the MUC5B gene. However, this alone is not sufficient to cause disease, and it's thought that the contribution of multiple common variants together is what leads to disease. And so you may ask the question, can we combine the effects of common variants through polygenic risk scores to capture greater risk variability? And the answer is yes, this has been done. This is a polygenic risk score devised using prior genome-wide association study data. And so they pulled together the common variants, and what they found was that in those who scored in the top quintile, they had a 7-fold increased odds of IPF than those who scored in the first. The next group of variants we'll discuss are the rare variants. So we'll start with the ILDs of with known inherited diseases. So these are monogenic diseases such as acid-sphingomyelinase deficiency, neurofibromatosis, Hermanzi-Pudlak, or lymphangioliomyomatosis. So these are rare variants which carry a large effect size, also meaning they're more highly penetrant, meaning if you carry this gene variant, you're more likely to express or have manifestations of the disease. The other group of ILDs from rare variants are related to those in groups of genes that are associated with specific pathways. So telomere maintenance, surfactant-related genes. So surfactant is what coats your alveoli to reduce surface tension, and it's also involved with modulating the immune response. You also have mitotic spindle assembly genes. These are genes that are involved in lining up your chromosomes during cell division. And so the one I want to highlight a little more is telomere maintenance genes. So telomeres are catalyzed by, are made by telomerase. So this is a specialized polymerase that adds telomere repeats, which are the TTAGGG. These repeats, they add it to the ends of chromosomes. These telomeres protect or preserve the structural integrity of DNA during cycles of cell replication because they shorten over time. So abnormally short telomeres is pathologic and leads to cellular senescence and apoptosis. And so you can see here, the telomerase enzyme is made of several components. You have TERK, discarin, et cetera. So mutations in any component of the telomerase can eventually lead to disease and will affect the ability for the addition of telomeres. And so how does this manifest? These are known as telomere biology disorders or short telomere syndromes. You can see the clinical manifestations that range from premature graying to pulmonary fibrosis, bone marrow suppression, and or cryptogenic cirrhosis. And this is important to highlight because when we ask about family history, if there's a concern for a telomere biology disorder, you're not just asking about do they have pulmonary fibrosis, you're also asking do they have premature graying or do they have bone marrow suppression? Because if you have two individuals in the same family with the same genetic variant, they can present in different ways, which is known as variable expressivity. And so when we ask the family history, it's a rather involved process. And why does this matter? So knowing what the underlying cause of the ILD matters because it affects treatments and prognosis. In terms of treatment, we do give patients antifibrotics, but it's also very important that we avoid immunosuppression. It has been shown that in these patients, immunosuppression leads to harm. Patients do worse, have more rapid decline in their forced vital capacity and worse survival. And sometimes it may be very difficult to tease out because these patients can also present with essentially any radiographic pattern. It can look like an inflammatory subtype of nonspecific interstitial pneumonia. So you may say, maybe let's try some immunosuppression, but this would be harmful in such patients. But it's important to note that these patients can get transplanted, but it's important to know what their telomere status is because it can affect their immunosuppressive regimen. These patients should get more tailored immunosuppression, and in this case, in our kind of work with Dr. Seetham Raju, who's the lung transplant doctor here, we always talk about it's important to know this because he wants to know about how it's going to impact his immunosuppressive regimen for patients. Screening-wise, we also want to make sure we're checking the extrapulmonary manifestations of this disorder from bone marrow, which can lead to cytopenias, acute myeloid leukemia to myelodysplasia, as well as cirrhosis. Obviously, there are considerations in the family, and so genetics is involved, depending on the mode of inheritance. So you might ask the question, if short telomeres are the issue, can we elongate them? And in fact, this has been done or studied. So this is born out of studies from the bone marrow failure side where they have used androgens, and some prior studies have shown that it may elongate telomeres. This is the telescope trial and studying danazone in randomized control fashion. Unfortunately, these results were presented last month. The study was terminated early due to futility because danazole was found not to be able to lead to telomere attrition. And also there is no change in the secondary outcome of change in forced vital capacity. So this is an illustrative schematic that summarizes the relative genetic contributions in ILDs. So here you have your rare variants. So rare variants, while they're highly penetrant, meaning the patients who carry it are likely to manifest disease, they make up a small proportion of those that were thought to have genetic etiologies of their ILDs. Meanwhile, the majority of disease risk is thought to be polygenic with a contribution from multiple common variants. It's estimated that 50 to 60% of patients with a suspected genetic etiology have no identifiable genetic cause. And I think this is for multiple reasons that there are research gaps. We still don't fully understand epigenetics, transcriptomics, proteomics, metabolomics, as well as exposomics in this setting. Finally, to kind of wrap this up and put a more clinical kind of approach to this, there are no guidelines for the management of genetic ILDs. So this is one that's been proposed as a suggested approach in a patient who you think may have a genetic form, as we normally do very extensive clinical history, as well as construction of a pedigree. We ask about family history, which is very important, and we look at features that are suspected of a genetic lung disease, mainly genotype-phenotype correlations. And so there's a table here that I have that highlights the genes that have been associated with adult forms of ILD. And so sometimes it can be hard because you do have to know what are the clinical phenotypes of these diseases. We recommend targeted genetic testing for that reason so that you don't get a lot of what we call variants of unknown significance, because if you test many, you'll get a higher rate of these. And so other indications for genetic testing is if you have a onset at an early age or rapidly progressive form. The other thing I would just want to highlight here is that in patients who have a negative family history, it's important to follow up at subsequent visits to see if this changes. And this can be for a number of reasons. Number one, the first time a patient's given a diagnosis of ILD, they might not know their family history, or they might go home later on, talk to their extended family, and find out that there is in fact a family history of ILD. Or these things evolve over time. Their family member didn't initially have it, but a few years later, they too develop it because some of these are diseases of older age. So going back to our patient, as we recall, this was the CAT scan on admission and on follow-up. So, and what was his diagnosis? The answer is a little tricky. It's a little all of the above because it's not clear cut what exactly happened, but what we suspect is that the current radiographic pattern he has is one of probable UIP or maybe a fibrotic NSIP. Because we had no prior imaging, one of two things can happen. Either he had a subclinical ILD, also termed interstitial lung abnormality, meaning there are radiographic changes but not clinically impactful, such that he did not have symptoms, and we don't have pulmonary function testing, but those are presumed to be normal. However, he developed an acute exacerbation, and now he has a residual underlying pattern of a probable UIP. And we say probable because in his imaging, there was no definite honeycombing. Or the other possibility is that he developed an acute onset of a nonspecific interstitial pneumonia, organizing pneumonia pattern, and now he has residual fibrotic disease. I think the main thing I want to highlight is that when you look at this imaging, it can be very easy to look at it and say he had a multifocal pneumonia. This is just some residual scarring from his infection and move on. But it's important to kind of look at this a little further to say the pattern of lung injury he has isn't typical of that of just a post-infectious course, and kind of looks like one of these ILD patterns. So going back to our patient here, he had a phenotype of family history of pulmonary fibrosis. His father was diagnosed at 72. He now presents at 49. This is a display of what's known as anticipation, meaning subsequent generations develop disease at an earlier age, as well as he has premature graying. And labs did show critically short telomeres. So you can see here lymphocytes and granulocytes were both less than 1%. And so in this patient, in vitae testing, genetic testing was pursued, and he was found to have a TERT mutation. This was found to be a variant of uncertain significance, and overwhelmingly variants of uncertain significance, or VUSs, remain as of uncertain significance. But in a patient in whom you have a very high pretest probability, it warrants further investigation. The American College of Medical Genetics have specific criteria for what constitutes a benign, likely pathogenic, or a variant of uncertain significance. Basically, there's specific criteria, and in our case, this variant did not have enough evidence one way or another, so it's a VUS. However, in looking at more of the details of the variant, it's absent from population databases, which means we don't see it in patients who are healthier. Secondly, this mutation, the missense change, has been seen in patients who have TERT-related conditions. So not pulmonary fibrosis, but seen in leukemia, myelodysplasia. There is a modeling that has predicted that this mutation leads to a change in protein function, and functional studies have also shown that this reduces telomere elongation capacity. And so this patient was referred to genetics with the help of Dr. John E. Keller, as well as Dr. Michael Murray. A proposal was submitted for variant review and consideration for upclassification. So with that, this variant was upclassified to be likely pathogenic, for better or worse, for the patient. Take-home points, ILDs are not that uncommon. It's important to follow abnormal imaging to resolution. Radiographic patterns are not diagnosis and have a low threshold to refer to pulmonary ILD. Dr. Padilla and I are available if there's any questions, referrals, references, and a thank you to the ILD team, and most importantly, Dr. Padilla, who is my mentor.
Thank you very much. Thank you for the wonderful talk. I guess my first question is, can you expand on the relationship between ILD and lung cancer? Is it the population that basically comes together to have high risk of thoracic malignancy, or is it the milieu that's created by the ILD?
That's an excellent question. I think we don't still fully understand it. Certainly ILD patients have an increased risk of lung cancer. That is beyond just of not being able to detect it, because it's kind of hidden with all the scarring, where it's very hard to detect the nodules. But I think underlying it, they have an increased risk irrespective of that, and they tend to do worse also irrespective of that.
Thank you. Dr. Padilla? To expand a little bit, because
but this is source of investigation. And there is a milieu that develops in a fibrotic lung. There is acidification of the surrounding environment that kind of stimulates or prepares a niche for either metastasis or to develop cancer. There are also Wnt pathways that are similar in cancer as they are in pulmonary fibrosis. So there is going to be confluence of many reasons why patients with ILD specific fibrotic ILD. And I think that it's very important we look for it out with make a difference in integration when we find it early, able to intervene with predominantly surgical intervention.
Yes, wonderful lecture. Thanks. I'm wondering if the case that you presented had an association with potentially with a post-infectious etiology, and I think there were specific infections or pathogens might be more likely to be exacerbation of ILD. And then I guess the second question is maybe a little bit unrelated, but with respect to genetics. After you start genetic testing.
So to the first question, yes, that's a very important distinction too. So we do suspect that there's probably some residual sequelae from the acute exacerbation, but he did grow Haemophilus on that, and so we think that there's two things going on. Viruses, bacteria, these things are also it falls under the exposome that we talk about in terms of risk factors leading to ILD. So exposome includes infections. More commonly we've seen in viruses in particular, but these are thought to increase the risk of disease as well. In terms of the second question, genetic testing is done in those who have a suspected etiology. So either they have a family history, if they're very young, less than 50 years of age, or they have a rapidly progressive course. So we don't do it for everyone. And generally, I would say it should be referred to a specialist, and also people who kind of know the genotype-phenotype correlation. So understanding what genes are associated with adult forms and what are the phenotypes. So in this specific example where the patient had multiple features of a telomere biology disorder, targeted testing was done specifically for that. And in another patient where they may have liver issues, or hepatosplenomegaly, transaminitis, cytopenias, you may think of a lysosomal storage disorder, and you would kind of go towards that pathway. So this genotype-phenotype correlation is an area of active need, and there's going to be more research into this as well. ClinGen is a NIH-funded study that is working on curating. So the panel that I showed is what several authors have put together, but this is an active area where we're working to systematically create a panel and also work on guidelines to address this need. Yeah, very important question. So right now we just have two. For idiopathic primary fibrosis, both of these are approved. For non-IPF fibrotic forms, unfortunately, only nintedanib is approved. So sometimes that makes it easier. You only have one agent. In terms of if you have both agents, then you want to consider the side effect profile. So nintedanib, unfortunately, a major side effect is diarrhea. About 2/3 of the patient may have it to some degree. For pirfenidone, and the other thing to consider is there's been a slightly increased risk of major cardiovascular events. So in patients who had a recent MI, you want to avoid it. In patients who have a bleeding risk, you want to avoid it. Pirfenidone, it does have an association with photosensitivity. So for example, I have people who are farmers, they're out in the sun all the time. So, I would then opt for the other agent. I think the landscape is shifting with the addition of nerandomilast, which is undergoing this process to likely be FDA approved in the next, end of the year maybe. And so I think we'll see how that pans out. But what the studies have shown is that this is effective in patients who are naive, not on treatment, or have failed current antifibrotics. And they've also been shown to have benefit in patients on antifibrotics, whether pirfenidone or nintedanib. And so we kind of have more to add. And I think this is where the field is shifting to, that it's not just one agent to treat the disease. It's similar to asthma, to pulmonary hypertension, where it's a multimodal approach to treatment. I'm sorry. Yeah, so if we see that there's signs of a fibrotic lung disease, there are some patients, some people who kind of wait to start it later. But if we see that they have lung disease, we opt to treat earlier. Because once the fibrosis is there, it's irreversible. And so if we know that there's a lung disease, I would opt for treatment right away.
If we're those to discriminate PF versus SID, then if so, what's the like?
Let me see. Is it the? It's very specific, but depending on which graft it was. Which one? Was it one of these? Going back? Forward.
Yeah.
Yes.
And so you're looking at, like, are you comparing diagnosis against the like?
The MDD, the multidisciplinary group. Correct. Similar for UIP and NSIP, it did decently well. The other subtypes, obviously, they have a much smaller sample size, so they're not as robust.
Like the committee reports allow against the like diagnosis.
The algorithm does
It's just
the algorithm compared to the MDD diagnosis.
Any other questions? All right, well, thank you very much for a wonderful talk.
Thank you very much.